happy to be here today. And I have to have a full disclosure, like all clinicians. I'm high right now on drugs, and I'm high on the drug of caffeine. I have had coffee and lots of chocolate in order to be able to speak, because one part of MS right now is my voice. It's hard for me to articulate as well as I'd like to. So thank you for having me here. I really want to talk about a really upsetting phone call I had 6 months ago from my friend Connie. She has MS. She lives in New York City. She's about 10 years younger than me, younger in age and younger in the advancement of her MS. And she called me really kind of close to tears, saying, I've just been fired by my neurologist. And I knew what she meant. I'm not sure other people would know that. But I had quite similar experience. She had a scheduled visit with her neurologist to discuss her recent MRI. Her disease was progressing, and she felt the MRIs would confirm that she didn't feel that the drug she was on was working. And indeed, when she showed up for the appointment, the clinician said, your MRI shows many more new lesions, confirms what you say. You don't feel that you're doing better. And he said, Connie, I really have had a great journey with you, and we've been through all the drugs and all the infusion therapy. We've been through plasmapheresis with you, and nothing has worked. And there are no drugs right now that I feel comfortable prescribing for you. So I think instead of our 6 months with visits, we should go to yearly visits. And then he was interrupted and went off, said, see you next year. And she felt she was fired. She felt, in reflection, she felt shame and guilt, and that, well, why am I so lost, and doesn't he like me? He was my partner. I thought we had a sacred relationship, and now he wants to see me in a year, at a time when my disease is getting worse and worse, and there's nothing left that he can do for me because of this disease. So I was really saddened by this story, but it was the same story I had when my disease kept progressing and there was nothing more that could be done. I tried all the medications and therapies. My physician, again, recommended that come back in a year. And my physician and her physician are loving, caring, wonderful physicians. We're very lucky. So what does that mean? I kept thinking of this talk. What wisdom, if I may say wisdom, thoughts I might have about her experience and my experience, and many, many other patients who suffer from severe chronic illnesses. One is that my clinician and other clinicians come to the clinic room with their shirts rolled up had their caffeine. They're happy to see me because they have tools in their toolbox. They're drugs. And I personally, and Connie, was treated with all the usual drugs. Now they're new experimental treatments. And we've tried them, and they've all, quote unquote, failed and were failures, which is a horrible term to label patients when nothing works. But that's what happens with chronic illness. Eventually, if you're not lucky, there's nothing more to do. So what's a clinician supposed to do? What was a clinician? What was he going to offer her? And clinicians are typically seen by patients, and I think by themselves, as at least they were trained to be superheroes. They're superheroes, but they wear capes, and they would go into the office and fight disease, fight illness, beat that down. We're working at it together, and we'll have tools, our toolbox, and we know what we're doing. But then there's a tsunami of changes in our healthcare. One is half the population in the next decade are going to suffer from chronic illnesses. So physicians' practices are going to be filled with people with chronic conditions where there's no cure, there's no bullet, and they haven't been trained, I think, fully trained to deal with this sea change in terms of what medical care will be about in terms of chronic illness. So I think that increase of chronic illness is in parallel with the fact that 50% of physicians now, according to the Mayo Clinic study that just came out recently, 50% of clinicians suffer from burnout or depression. And we have to deal with that. And how, I'm not sure, but I think that has to be one of the major things that we should deal with in medical education. And I chose this slide about a puzzle because it's all a complicated puzzle when you're dealing with chronic disease. And there's a big hole in this puzzle. That's the elephant in the room no one really wants to talk about in the clinical setting and the patients around, is that the medical system currently does not support clinicians. How can you treat a person with complicated chronic illness in 10 minutes? Can't do it. You don't have time to listen and provide wonderful care or quote-unquote elegant care. Forget it. You can't have time. You just do not have the time or the ancillary resources like therapists and all the other helpers that can work with a clinician to provide kind care. So what are we left with? We have to develop new tools in the toolbox. And I think that's what medical education should be worried about, is making sure that there are more tools in the toolbox so that you don't have to see your physician once a year because there's nothing to be done. And my feeling, my personal feeling, is that we need to work together, physicians and clinicians, that we have to develop empathy for physicians, and physicians need to develop more empathy for patients. It has to be together, and if there isn't dual empathy, it's not going to work. What I mean, it's not going to work. There's no way to pressure the healthcare industry unless, whatever that means, healthcare industry, the providers, we have to join forces, the patients, the clinicians, to force healthcare industry to pay attention to the dilemma of burnout and depression with providers. When I talked to Larry Chu, he said, you have to have takeaways from this talk. So these are my takeaways. One is, if we can train physicians, be comfortable saying, I just don't know. I just don't know. And you say it to a patient, at least in my experience, I get so excited when my physician says, Elizabeth, I don't know, but let's think about things together. And the other thing is how we can teach medical students to look at patients, really look at them, observe them, and ask questions, not diagnostic questions, but Elizabeth, what does it mean? You can't eat. You have to have assistance. What does that mean for you? What does it mean you can't comb your hair? Or what does it mean to have a catheter? What do you feel about that? What are you doing about that? And I think these quick observations or slow observation could be done fairly quickly. And so my desire is that clinicians observe, think, and use the internet. There are all sorts of resources now in having medical students have an understanding of the intimate details of living with chronic disease. And what we have on the screen now is a photograph of Jason De Silva. He's a famous filmmaker. He's an award-winning filmmaker. He has a chronic progressive MS, and this is a photograph of him getting assistance in the subway where the elevator is broken. And so he's being carried up 3 flights of stairs so he can make the subways to get home. And that is more the kind of empathy training, just looking at what Jason's going through. And what I like about this photo, you look carefully, you see his underwear. And I thought, well, that's the example of the humiliation you go through when you're transferred. And I know that personally because I got 2 gift cards to Victoria's Secrets this week because I have terrible underwear. And where I work out, the people there said, listen, you need better underwear because I see your underwear every session and you have grandma underwear. I want you to have something sexy for us to look at. And when I saw this view of Jason, I thought, that speaks volumes. And now I'm waiting for a video. That's one of my pieces of art. It's a video which I worked on last year. What I'm working on now, I'm not sure that was the total video, but I'm working on employing what we can do better in our hospitals and clinics to create empathy between clinicians and patients, and that are conversation cards. And if all of you could look at the conversation cards under your chair. And I'd like to ask you at some point to fill out the conversation card. What I'm trying to do is, how can we develop empathy? I don't know why Connie's physician didn't want to see her in a year. Probably because he was depressed. He felt impotent. And he probably was terrorized, not terrorized, but upset about the fact he didn't have any skills when he didn't have anything in the toolbox. I would love it if I knew him, say, if I had a conversation card which would indicate his feelings. And I'd like conversation cards which would indicate the patient's feelings. And if we could have these in waiting rooms or in clinic settings, we can spur conversation, and they don't have to be heavy conversations, but a slice of reality of our different realities. And we need, I think, to talk together and share. And I would, let me summarize, because I think I'm done with my talk by saying, I think is that we have to have conversations, critical conversations amongst each other, and we have to lead our fight that we need the healthcare industry and the financial system to recognize that we all are in the same place. We want kind, loving care. We want to empathize and to truly work together to provide health care and to have a loving, I know it sounds terrible, but Victor gave me permission to say loving care. And I hope this is one of my piece of artwork of my brain, And it was an example of how we can talk together and empathize. I think that's key. And I think if we clinicians and patients could lock arms together, we can make progress. Thank you.